We're now going to discuss structural causes of cardiac syncope. You know fundamentally that the heart is a pump, which requires, therefore, reliable electrical control signals and reliable muscular contraction and an unimpeded flow of blood through its chambers. Failure to produce this mechanical effort or obstructing it in any way can cause syncope through a supply-demand mismatch. A very common example is obstruction to the outflow of blood through the aortic valve from the left ventricle to the aorta. To conserve energy used in pumping, valves in the heart, like in plumbing, should impede greatly the flow of blood in one direction and offer no impedance in the other direction. In the case of aortic stenosis, it fails by impeding flow when it shouldn't. It stops blood leaving the ventricle when it shouldn't. When the ventricle contracts, a normal aortic valve will transfer the pressure generated in the left ventricle during systole to the aorta. In diastole, when the ventricle is relaxed, the blood under aortic pressure does not return to the left ventricle. The valve allows flow in one direction but not the reverse, thus conserving energy. When the valve is stenosed, the left ventricle must generate a much higher pressure during systole so that the blood can exit through the narrowed aortic valve. There is a difference or a gradient in the left ventricle and aortic pressures, as can be seen in these tracings. When the body demands a greater blood supply, such as during exercise, the narrowed valve does not allow supply to increase, and so organ hypoperfusion may result. Angina from hypoperfusion of the heart, and syncope from hypoperfusion of the brain. Over time, the narrowing progresses, requiring even higher pressures to be generated by the left ventricle. Over many years, the heart compensates by increasing the size of the muscle, or hypertrophying. This can create secondary problems such as the limited ability to relax or a demand for blood supply that the arteries cannot deliver. Here you can see an echo image of the left ventricle here, which is thickened or hypertrophied, and it's done so to generate high pressures so that it can overcome the narrowed valve here. This is the aortic valve into the aorta. And because it's narrowed, it resists the ejection of blood flow, and so the muscle has hypertrophied to compensate for this. Over here is the left atrium and the mitral valve, allowing blood freely to flow during diastole from the left atrium to the left ventricle. So at the bedside, how may a patient who presents with syncope due to aortic stenosis be identified? Well, the ECG is useful as it demonstrates signs of hypertrophy with large QRS complexes. The more muscle, the more ions moving in and out, the greater the electrical currents, so the greater the QRS complexes. Also, because the valve is narrowed, the blood flows through it faster. That increased flow of blood is turbulent and noisy. This can be heard when listening to the heart with a stethoscope. It is best heard at the right upper sternal border and into the carotid arteries. Recognizing aortic stenosis is important because undiagnosed severe aortic stenosis results in death. Most often, the narrowing occurs over the years through wear and tear, known as degenerative calcific aortic stenosis. In the developing world, however, an immune reaction to rheumatic fever causes the narrowing most often. In both cases, it's treated by replacing the valve either surgically or through a catheter delivery of a new valve. This is known as TAVI, or transcatheter aortic valve implantation. Obstruction at the aortic valve is not the only thing that can cause syncope. In fact, obstruction at any part of the cardiac circulation can cause syncope. Another common cause is the obstruction at the mitral valve location. This is mitral valve stenosis. In the case of mitral valve stenosis, it is the left atrium that has to overcome the obstruction, just like the left ventricle had to overcome the obstruction in stenotic aortic valves. This results in dilation of the left atrium. The ECG, therefore, shows signs of enlargement of the left atrium, or P mitrale. The P refers to the electrical activity of the atrium, and because it's the left atrium attached to the mitral valve, it's called P mitrale. This is best seen in lead 2, where the P wave has a double hump or is bifid in appearance. On auscultation, when listening to the heart, because again, the narrowed valve causes fast flowing blood through it, it results in turbulent blood flow. In the case of mitral stenosis, this occurs in diastole, when the atrium contracts, and it is heard as a low-pitched diastolic rumble, as well as an opening snap. As with aortic stenosis, this is diagnosed using echocardiography and is treated with replacement of the valve. It's not just the valves that can obstruct blood flow through the heart, but also, in some cases, the very muscle itself. Hypertrophic cardiomyopathy is an inherited condition affecting the formation of muscle in the heart. It results in excess, disorganized muscle growth, and associated with that is also scarring or fibrosis. Most often, the thickening is located and isolated to the septum of the left ventricle, which is located here. So again, how might you identify this patient were they to present with syncope? Well, the greater volume of muscle that they have can result in a modification of the ECG signature, as is seen in this ECG. The inferior leads, 2,3-AVF, show marked Q waves, and V1 shows an abnormally large R wave, which is never normal. This image is taken from a transthoracic echocardiogram of a patient with hypertrophic cardiomyopathy. The septum is so thick that it is obstructing the path of blood ejecting from the left ventricle to the aortic valve. This is the left ventricular septum. This is the cavity of the left ventricle. Here is the aortic valve open and the aorta out here. This is the left atrium and the mitral valve, and the papillary muscle is marked here. And in systole, you would expect the blood flow to leave the cavity of the left ventricle and flow to the aortic valve, and unless that is also stenosed, it should exit without issue. But the obstruction here is from the muscle. This is why it was previously called subaortic stenosis, an obstruction not from the valve but below the valve. I have a diagram of the left ventricle aligned with the previous echocardiographic image. It may help to rotate the image to make the components more understandable, since it takes time to learn standard echocardiographic views. You can appreciate that the blood ejected from the left ventricle needs a clear path towards the aortic valve and thereafter the aorta. The thickened intraventricular septum in this hypertrophic cardiomyopathy patient limits this passage. Additionally, one of the mitral valve leaflets is pulled into this passage, further obstructing it. That is seen here. This is termed systolic anterior motion of the mitral valve, or SAM. And this occurs because the fast and eccentric flow of blood drags this leaflet with it. So you get two forms of obstruction when the left ventricular septum is involved in hypertrophic cardiomyopathy. In addition to the history, physical examination, ECG, and echo that we've seen so far, a cardiac MRI can be helpful. This is because it can characterize the degree of scar or fibrosis in the thickened muscle. In MRI terminology, this is called late gadolinium enhancement, or LGE for short. The more LGE, the more scar, the more scar, the more likely ventricular tachycardia is likely to happen. This, along with the other risk factors seen here in the corner, family history of sudden cardiac death, massive left ventricular hypertrophy, so very thickened septa, unexplained syncope, an apical aneurysm, and a poor ejection fraction. These together with the scar that's seen on MRI can predict sudden cardiac death from these ventricular arrhythmias. And this is useful for cardiologists and cardiac electrophysiologists as it informs them of the need for an implantable cardioverter defibrillator, or ICD, to shock these patients out of this dangerous arrhythmia. So not only do these patients have hemodynamic issues, the inability to pump blood efficiently out of the left ventricle, but they also have electrical issues and are at risk of sudden cardiac death. One key form of therapy in patients with very thick left ventricular septa is to remove that thickened tissue. This is known as septal reduction therapy. This can be done in two ways. One, by injecting alcohol into the artery supplying the muscle, resulting in its death, or by surgically excising it. That's a myomectomy. So once diagnosed, a cardiologist must follow these patients up throughout their lives, keeping several key considerations in mind. Dehydration, for one thing, should be avoided as it reduces the blood circulating volume, which can exacerbate the left ventricular obstruction. Dehydration increases the likelihood of obstruction and consequently syncope. So staying hydrated reduces the risk of obstruction and syncope. When it comes to stroke, hypertrophic cardiomyopathy patients are at increased risk. They're also at increased risk of atrial arrhythmias. As such, they are required to be anticoagulated regardless of risk scores. So for instance, in a patient without hypertrophic cardiomyopathy, you may use a CHA2DS2-VASc score or a CHAD score to calculate whether you should offer anticoagulation to a patient. But in contrast, hypertrophic cardiomyopathy patients with atrial arrhythmias should receive anticoagulation due to their increased baseline stroke risk. When it comes to rhythm monitoring, it's crucial in these patients, both for atrial and for ventricular arrhythmias. Regular imaging is needed to keep track of the progression of the obstruction using echocardiography and to assess scar burden also using cardiac MRI. When it comes to treating these patients, the cardiologist will typically prescribe maximum dose beta blocker if possible, and this is to prevent ventricular arrhythmias but also to slow the heart rate, thereby reducing obstruction risk. In high-risk patients, they may be offered an implantable defibrillator to prevent sudden cardiac death. And finally, because this is a genetic disease, hypertrophic cardiomyopathy is a genetic disease, genetic counseling and testing are recommended for patients and potentially their family members, as it can affect them too.